outset, let me thank the organizers for giving me this opportunity to speak today. And my topic for presentation is androgen deprivation therapy in prostate cancer. This is a very important topic as far as prostate cancer is concerned, and it looks like somehow androgen and hormone dependence of prostate cancer remains from beginning till end, and that's what we will see when we have this presentation today. Starting with a bit of a history, the scientist Charles Huggins was established this over 75 years ago in the work that led to his Nobel Prize winning work. Huggins found that bilateral orchidectomy could slow the growth of the disease. He was awarded Nobel Prize in 1966 for physiology or medicine for discovering in 1941 that hormones could be used to control the spread of some cancer, and prostate was one of the sites. Now, what is the mechanism of ADT in prostate cancer? Testosterone production is regulated by luteinizing hormone, and luteinizing hormone and releasing hormone which controls the luteinizing hormone. The hypothalamus releases LHRH, which stimulates the release of LH from the pituitary gland. LH acts on the specific cells in the testes to produce the majority of testosterone in the body. Most of the remaining androgens are produced by adrenal gland. What is the normal physiology? Prostate requires androgenic hormone and an intact androgen receptor for normal growth and development. The major circulating androgen hormone is testosterone, and testosterone, with the help of 5-alpha reductase, gets converted into 5-alpha dihydrotestosterone, and that is inside the prostatic stroma. What is the function of this? It is more potent than androgen than testosterone. It binds to intracellular androgen receptor and activates the expression of selected target gene. And this leads to stimulation of cell division, inhibition of apoptosis, and cellular differentiation. Whatever I talked about, this is what can be seen here. Hypothalamus releases LHRH, then pituitary gland releases LH, and that leads to having the production of androgen, and that gets converted into dihydroxyl testosterone, and that leads to proliferation of cells in the prostate tissue, and some of them becomes aberrant, and that leads to prostate cancer, and that also becomes dependent upon these hormones. Now, ADT in different settings, and what I want to highlight with this slide is either we take localized disease, asymptomatic disease, then also there is a potential role of hormone therapy, either alone or in combination. If the disease volume increases, that is locally advanced disease, then also there is an important role of hormone therapy, either alone or in combination with local therapy. And yes, if you do have advanced disease, that is metastatic disease in prostate cancer, then you do have a very important role of hormonal therapy, which remains till they become resistant to it, but it does remain dependent in some form or other on hormone till end, and that's the reason the role of ADT in prostate cancer remains from beginning till end. There is a risk stratification for localized and locally advanced prostate cancer. And this is just to highlight when we talk about the different type, where are the situations where we think about giving hormonal therapy as a treatment in localized and locally advanced prostate cancer. These are high and very high risk group prostate cancer, which is fairly well established. Now, starting with the new adjuvant ADT and where we use it. Do we have any role of neoadjuvant ADT with radical prostatectomy? There has been some data on this. Men with large early stage prostate cancer with intermediate and high risk group may be considered for neoadjuvant ADT prior to primary treatment, especially surgery, because it does improve progression-free survival, but it doesn't have an impact on overall survival. Longer duration of treatment appears that they do have more impact on controlling the disease as compared to shorter duration of treatment. But again, in this situation, the neoadjuvant ADT, if you can do the surgery upfront, the role remains limited, and that is not routinely used. So this is take on this. The neoadjuvant ADT significantly reduces recurrence and the positive surgical margin, but its impact on overall survival is limited, and that's why we don't routinely use it. What is the role in adjuvant ADT following radical surgery? Adjuvant ADT improves the 10-year rate of systemic progression-free survival, the disease-free survival, compared to ADT following PSA increase in these patients. And we will see subsequently how we can give it and how we can combine it. So in the high risk patient, there's a potential role of adjuvant ADT in these patients. What can we take here? That adjuvant ADT following radical prostatectomy is supported by strong evidence for patients with high risk localized or locally advanced prostate cancer, particularly those with positive lymph node. Highlighting, yes, you do have a role, but not all patients. In a small group of patients where the patients are at very high risk of failing, then one can consider using adjuvant ADT post-operatively. Adjuvant radiotherapy plus ADT following radical prostatectomy. There is now a relatively strong evidence to support that combining adjuvant ADT with adjuvant radiotherapy following radical prostatectomy in which the meta-analysis has shown that it improves outcome compared to only radical prostatectomy in these patients, especially in the high-risk group patients. It appears that 5-year biochemical relapse-free, metastasis-free, disease-specific, and overall survival rate were 90% if the ADT was combined with radiotherapy. There has been always a question that what should be the timing of this the treatment, the adjuvant treatment with ADT. We should give now, or we should give when there is a biochemical failure. This was one of the study called TOAD study, which suggested that immediate ADT significantly improves overall survival as compared to delayed ADT in this setting. And again, highlighting the role of immediate ADT in this setting, which can be considered if the patients are at the high risk of failure. This was another study, that is a French study, salvage radiotherapy plus ADT versus salvage. And it also, the salvage radiotherapy plus ADT was better as compared to radical radiotherapy alone. So adjuvant radiotherapy or salvage radiotherapy alone in this setting, highlighting that the ADT has a potential role in this setting, and giving radiotherapy alone may give a suboptimal result. Long RTOG 9601 study investigated long-term ADT plus salvage radiotherapy versus salvage radiotherapy alone in patients with rising PSA following radical prostatectomy. So we follow the patient, and if the PSA starts rising, and what we can see here, the addition of 24 months of ADT improved 12-year overall survival, which was statistically significant, and the reduced 12-year rate of metastatic prostate cancer in these patients, which was again statistically significant, and also prostate cancer specific mortality in these patients, highlighting the use of radiotherapy plus adjuvant hormonal therapy in the patients where there is a biochemical failure in these patients, and there is a potential role of hormonal therapy. Again, coming to biochemical recurrence, the radiotherapy plus ADT is recommended at the time of biochemical failure, especially for patients with Gleason 7 or more, PSA 0.7 to 4.0, and or for positive surgical margins in these patients. RT plus long-term ADT has overall survival benefit. So there is a potential role in patients having high risk disease, and if you have not given at that time, then when you do have a biochemical failure, then this option remains for these patients, which may benefit these patients. Now, ADT in the patients with RT radiotherapy, which the radiotherapy is the primary treatment. This is one of the studies which showed that 6 months of combined androgen blockade plus radiotherapy significantly improved overall survival compared to radiotherapy alone in men with intermediate risk localized prostate cancer. In another study, radiotherapy plus 6 months of concomitant and adjuvant ADT improved biochemical and disease-free survival compared to radiotherapy alone. Coming to evidence for neoadjuvant ADT followed by RT in intermediate risk prostate cancer. In one of the study by RTOG, short-term combined androgen blockade for 4 months before and during radiotherapy was associated with decreased disease-specific mortality and increased overall survival. RTOG 9910 study investigated the treatment with 8 weeks of ADT versus 28 weeks of neoadjuvant combined androgen blockade plus 8 weeks of combined androgen blockade during radiotherapy. And they had a similar outcome. Hence, ADT with 8 weeks before and 8 weeks during the radiotherapy may be good enough in this setting. ADT in patients with radiotherapy as a primary treatment in intermediate risk group, what we can summarize with all the data we have. Short-term ADT in combination with LHRH analog and anti-androgen blockade, anti-androgen to provide the benefit to the men with intermediate risk prostate cancer, particularly those with unfavorable intermediate risk group disease with no or minimal comorbidities. Short-term ADT, that is neoadjuvant plus concomitant for 4 months, is recommended for intermediate risk group patients for whom radiotherapy is as a primary treatment. Radiotherapy plus ADT for high risk group patients, and what we can see here that you do have multiple studies which suggest that in the high risk group patients, neoadjuvant hormonal therapy during radiotherapy and followed by prolonged hormonal therapy in this situation improves overall survival, and in many situations the overall survival improvement, that is absolute overall survival improvement, has been in the tune of almost 18 to 19% with hazard ratio of 0.6 and p-value being very significant. Radiotherapy plus ADT for high-risk, localized, and locally advanced prostate cancer. The long-term use of ADT concomitant or adjuvant with LHRH analog with or without an anti-androgen is correlated with improved PFS and overall survival in patients with high-risk or locally advanced non-metastatic prostate cancer. Alternatively, a short course of ADT may be sufficient for patients with intermediate risk prostate cancer, highlighting that in locally advanced prostate cancer, you have a very important role for ADT to play to improve survival in these patients. Now, ADT in patients unfit for or unwilling for primary treatment. We have a significant proportion of patients in prostate cancer who is not willing for local treatment as radiotherapy or surgery. In these situations, ADT can be used in men with localized or locally advanced prostate cancer who refuse or are not candidates for primary treatment, including those with limited life expectancy, advanced tumor stage, or other serious comorbidities. It appears that if given, especially in immediate treatment, have a symptom, especially in this setting. So if we have to summarize, as far as non-metastatic prostate cancer is concerned, and what it highlights that if you are giving the treatment with surgery, then primarily you may not be giving hormonal therapy to these patients, but subsequent to surgery, if the patient is a high risk patient, then you need to consider them for hormonal therapy, in this setting. If there is a biochemical failure, again, there is an important role here. If the patient is locally advanced disease and with the high risk feature, then again, role for having hormonal therapy in this setting becomes important, and it appears that immediate hormonal therapy or deferred hormonal therapy, one of the approach will be important in these patients. Again, if they fail biochemically, then radiotherapy plus hormonal therapy is important. In patients receiving radiotherapy as a primary treatment, in the intermediate risk group patients, hormonal therapy is important with radiotherapy. It is usually short term. In the high risk patients, it appears that radiotherapy plus hormonal therapy is important treatment, and here hormonal therapy is going to be long term and needs to be given to for 2 to 3 years. In these situations, if the patients after treatment they do fail biochemically, then in these patients giving hormonal therapy again may be useful subsequently. Now, what are the modalities what we can use for hormonal therapy? We can give surgical hormonal therapy, and in medical hormonal therapy, we do have LHRH agonist, LHRH antagonist, anti-androgen, androgen synthesis inhibitor, and also estrogen. Out of these, surgical castration and LHRH partial agonist and antagonist, these are primarily in use in the clinic. Now, what are the agents used? Again, highlighting where they are used and what we can see that when we use these, partial agonist and antagonist, they work at between hypothalamus and anterior pituitary, where they work on GnRH hormone. If we see the surgical castration, they remove the testicles and testosterone is not produced. If we use ketoconazole, epinephrine, acetate, or corticosteroid, they work at a different level that is there in the cellular level, where they stop the conversion of steroid into becoming the active testosterone. Starting with surgical castration, surgical removal of the testicle was the earliest form of hormonal therapy, and as I told earlier, that Dr. Huggins got the award for it. And what they observed when it is done, they monitored the changes in the prostate size and observed that improvement in acid and alkaline phosphatase were associated with cancer-related symptom relief. If we do this surgery, then the androgen comes to castrate level within in a very short period of time. Many patients find it psychologically unacceptable. That's one of the limitations. And apart from that, some patients are not surgical candidates owing to advanced stage. So these are some of the limitations of surgical castration. But this is one-time procedure, easy to do, and fairly cost-effective in our country and especially in our region. The advantages are that it is preferred in initial treatment in the patient with impending spinal cord compression or ureteral obstruction, especially when we can't give antagonists in this setting. Logistics and cost of continuous medical ADT in metastatic setting has to be borne in the mind, especially again in the country we are from, and especially in the region we are from. It immediately reduces testosterone to castration level, which is a huge advantage. Coming to LHRH agonist is synthetic protein, structurally similar to LHRH and binds to LHRH receptor in the pituitary gland. It leads to intermittent false LHRH, leads to sustained FSH and LH release. High dose and continuous release inhibits the gonadotropin release due to receptor downregulation. Example, leprolide. You have leprolide acetate. Leprolide acetate, it is in the depot form. It is a coated pellets. It dissolves at a slow rate to allow sustained level. It is given intramuscularly either every 28 days, every 3 months, or every 4 months. Leprolide mini osmotic pump delivers 120 microgram daily for 12 months. You do have other options, goserelin implant that can be given monthly or every 3 monthly. Triptorelin depot then can again be every 28 days or every 84 days. These are the various options which can be used. What are the side effects? There are quite a few. There can be tumor flare, which we should be always concerned about when we are using, especially those agonists. There can be hot flashes, erectile impotence, decreased libido, injection site reaction. There can be increased, especially in initial phase, there can be increased testosterone production, which can lead to increase in the symptoms, especially if there is an obstructive symptom in these patients, which usually resolves within 2 weeks. And if we have to use agonist, then we do use anti-androgen with this agonist in this situation. Otherwise, antagonist or surgery is a better option. Now, LHRH antagonists, it binds irreversibly to LHRH receptor in pituitary, thus reducing testosterone to castrate level. The major advantage, the castrate level testosterone reached within 7 days as compared to 28 days what we see in agonists. Example is Deprivation. It has been recently approved by FDA for advanced prostate cancer, starting dose 250 milligram followed by 80 milligram every 28 days. Do we have anti-androgen, which we have been using for quite some time? It binds to androgen receptor in prostate cells, inhibits androgen uptake by prostate cancer cells, and this leads to growth of cancer cells being retarded. They are used in combination with orchidectomy or LHRH agonist. Their role as alone treatment has been limited. These are the options: flutamide, bicalutamide, and nilotamide, which is used in the clinic. Androgen synthesis inhibitor. It inhibits androgen synthesis in the testes and adrenal. It blocks the testosterone production by inhibiting an enzyme called CYP17, which produces testosterone from cholesterol. Three androgen synthesis inhibitors are approved in the United States, that is ketoconazole, aminoglutamide, and abiraterone acetate. Ketoconazole, it is imidazole antifungal, given 400 milligram TDS, strong inhibitor of CYP A1 and CYP3A4, therefore contraindicated for many drugs when it is being given. Its absorption requires gastric acidity, so should not be given with H2 blocker or PPI. Toxicity of ADT, yes, there are toxicities: fatigue, weight gain, osteoporosis, depression, cognitive dysfunction, erectile dysfunction, loss of libido, gynecomastia, anemia, decreased high density protein, and hot flashes. So one should be mindful about the side effects when we use them. There can be endocrine complications, osteoporosis, insulin resistance, dyslipidemia, sexual dysfunction, adverse body composition, gynecomastia, hot flashes, and metabolic syndrome. In these situations, reminding these are very effective treatment, but they do have their own toxicity when we use them in these patients. So monitoring and surveillance of patients becomes important. Physical activity should be encouraged in these patients because it appears they do have predilection to develop diabetes and cardiovascular disease, and these patients we should be careful about in this situation. Sometimes supplement with calcium and denosumab may be important in these patients to prevent osteoporosis. ADT alone in metastatic prostate cancer. This is in metastatic setting. It has been used upfront alone or with docetaxel, abiraterone, or enzalutamide, and has shown to be superior to ADT alone. Alone also, it has a very good symptomatic benefit to the patient and can be useful in the patient unfit for any systemic therapy. So ADT alone can also be used in today's time also to benefit in fair number of advanced stage prostate cancer. If we see NCCN and what we can see here in the localized disease, then if you are doing surgery, if you can do it, ADT is not encouraged. In the rest of the situation, you're giving radiotherapy, especially in intermediate risk patients and high risk patients, it is useful. And if you do have a high risk patient with high risk feature after surgery, again, adjuvant ADT becomes useful. In metastatic setting, it is useful in castrate sensitive prostate cancer. It is also useful in castrate resistant prostate cancer. Here, NCCN recommendation on optimal ADT, that if we use either surgical or medical, both of them are equally effective. Anti-androgen monotherapy appears to be less effective and should not be used alone in this setting. So take home message from my side. Hormonal therapy is an integral part of management of prostate cancer in almost any stage. For metastatic disease, hormonal therapy is the gold standard, and for early stages, hormonal therapy is given as per risk stratification but used in many settings. Thank you.